There we go. Thank you. Same disclosures. Nobody's contacted me in the 10 seconds it took to get those slides up, so no more money coming in. So the goal of functional rehabilitation is to correct the mechanical flaws that you just identified on the physical exam. You want to restore the integrity of the kinetic chain, and ultimately the goal is to reestablish normal function, not just to correct the symptoms, but to correct the dysfunction. Let's talk a little bit about function. There's an intrinsic and extrinsic function. Intrinsic function is the internal processes within the body, physiologic, biomechanical, and neuromuscular. And then extrinsic is the resulting movement or outcome of those internal processes. And Giovanni has referred to that. This is the sensory motor system. So the physiologic function includes the healing processes and tissue responses. Biomechanically, we look at the kinematics and the kinetic chain. And then the neuromuscular function is the level of motor control or learning or relearning, depending on where the patient is. And then when these are all integrated, you get movement, or that you get the control of movement, which is specific, purposeful, and synergistic. Postoperatively, our goals are to control pain, protect the integrity of the repair or reconstruction, restore the range of motion and strength. Basically, you want to make sure you reestablish the anatomy and physiology. But as we've been beating you over the head for the whole morning, there's more to function than anatomy and physiology. So to restore the normal anatomy, you're going to get repair and healing of the injured tissues. To restore the physiology, you want to get correct joint position and movement. The kinematics are restored by integrating the movements of the kinetic chain. And then the neuromuscular is controlling the movement and integrating the central nervous system with the musculoskeletal system. You've been hearing about kinetic chain. The best way to think about a kinetic chain is thinking about a group of kids playing crack the whip, where this is the stability right here, and the energy is being transmitted to this poor little child that's getting whipped at the end. But imagine what would happen if one of these kids bent his or her elbow. There would be a break in the chain, and the energy that's transmitted would be significantly decreased. Well, that's what we've got here, with the sea lion balancing a ball on his nose, and here's your scapula and the proximal kinetic chain. So it's more than the dynamic model is a sea lion balancing a ball. The static model is a golf ball sitting on a tee. There are open kinetic chains and closed kinetic chains. In an open kinetic chain, the terminal link is not loaded and it's freely mobile. So think about somebody doing an extension of their leg with their foot free. That's open kinetic chain, and in this case, a lot of stress on the patellofemoral joint. Much less stress if the foot is fixed, and the muscle activation is sequential, going from distal to proximal. So you're not going to load the patellofemoral joint as much if the foot is fixed. Well, the same holds true with the shoulder. So closed kinetic chain exercises, there are relatively small joint movements. There's very low joint acceleration, large resistance forces, a lot of joint compression, but very little shear, very little translation, very little distraction. You stimulate joint proprioception, and you get better dynamic stabilization by the muscle coactivation. So it's much safer to go closed kinetic chain, especially in the post-op patient, but it's much more functional. So what are the considerations when you're putting together a program? Well, you want to think about pain, range of motion, scapular position, core stability, postural alignment, kinetic chain, functional exercise progression, how much do you do and when, and what do you do with the patients are always asking, when can I run? So cardiovascular training is important. We're preemptive about what we do with pain. We do nerve blocks. Preoperatively, we do suprascapular nerve blocks. We use pain medication and anti-inflammatories, of course. Alan Barber has gotten me started on using sleeping medication one night pre-op and then the first night post-op. And we found that helps our patients deal with things. We tend not to think about immobilizing the joint, the shoulder joint. We think about protected range of motion. And based on the procedure, we decide what can and can't we do. And then, of course, we use modalities as we need to. Because a painful joint is not going to progress very well. This is not a no pain, no gain thing. Pain should be rehabilitation should be relatively pain-free. If there's pain, there's either too much inflammation, it's the wrong exercise at the wrong time, or the exercise isn't being done properly, usually because the muscles are fatiguing. So you really don't want to have a patient doing 3 sets of 10 if the last 2 sets are with poor form, because then they'll just learn bad form. We try to get our patients to the physical therapist early, especially the post-op patients. It allows us to establish control for the patient, let them understand what's going on. It calms the patient down if they know what good pain and bad pain are. They get to learn what to do at home, and they're given by our therapists or the therapists in our area guidelines for self-progression. So they have a pretty good idea. It also saves phone calls to the office, but they get a pretty good idea of what they have to do to handle the problem, the pain, and their progression. Again, we talked about immobilization. Really, it's protected range of motion. Depending on the procedure, you want to think in terms of, are you going to do active range of motion, passive range of motion, or a combination, or midway active assistive range of motion. That's procedure dependent. Flexibility is not something you're dealing with early on. Range of motion, you hear about pendulums quite frequently. Well, range of motion can be done as a closed chain and protect the joint. So if you have here you're going to have somebody that's working on lumbopelvic positioning and strength, and you have them put their hand on, what we usually have patients do is put their hand on a kitchen counter because it's higher, and then they just bend at the knees and bend at the hips, and they get a significant increase in the range of motion, but they're not loading the joint. You can do that after rotator cuff surgery. You can do that depending on the tear pattern in tissue and the quality of the repair, and you can certainly do that early on after stabilization. You can use, if you have somebody in therapy, you can have them doing closed chain ball rolls with a smaller ball when they don't have as much motion, progressing to a larger ball. The definition that I like to go with for core stability is the ability to control the position of the trunk over the pelvis to allow optimum production, transfer, and control of force and motion to the terminal segment in integrated activities. Dontrell Willis here. Core stabilization is very important. Paul Hodges, a physiotherapist in Australia, has shown us that the first muscle to fire is the transversus abdominis before your arm or leg moves. That increases the intra-abdominal pressure to start getting you ready for the movement of your arm or leg. So we do a lot of core stabilization work. We like our patients doing Pilates, and if we can get our patients doing yoga, that all the better, because then they get core stabilization and they get flexibility. But not all yoga is the same. This is Mr. Iyengar, who's got his technique for yoga, which is well respected. And then I grew up in the Bronx, and yoga for us was a little bit different. So core stability, you want to develop core and lumbopelvic strength, but you've got to be careful, because one of the compensations that people will make is they'll collapse the arch. So if you have somebody doing a single leg squat and they pronate their